A very good afternoon to all of you. It's again a very warm afternoon, and we would now today be talking on thalassemia. It was World Thalassemia Day, Awareness Day, a few days back, and we take up this topic on advancements of thalassemia today. And for our speaker, we have the very esteemed faculties. We have Dr. Nita RadhaKrishnan, ma'am, who's the additional professor and head, Department of Pediatric Hematology Oncology, Postgraduate Institute of Child Health, Noida. As our moderator, she has peer-reviewed 82 papers. She has peer-reviewed papers of 82 peer-reviewed papers. Her research interests are hemoglobinopathies, primary immune deficiency, hemophilia, childhood cancer. She's the co-editor of IAP guidelines for diagnosis and management of thalassemia. We welcome you, ma'am, to moderate the session, which is a very important session on advancements of thalassemia management. And we, of course, have Dr. Prantar Chakrabarti, sir, with us. He has been a leading hematologist for a number of years, and he was working as a teacher in the college in West Bengal, the NRS Medical College, for more than 17 years. And then he took a strategic time out to pursue his dreams and passion and improve health and fitness and do some meaningful work at the rural level. And he currently is in a small village in Tamil Nadu, and he is trying to, develop the entire system. And as we know, he's passionate and empathetic and has already contributed a lot in the field. So the floor is here to you, Nita, ma'am. Please, if you can take the session forward.
Hello, everybody. Thank you for this invitation. It's an honor and responsibility to be here with you on the occasion of Thalassemia International Day, which was celebrated few days ago, and to be moderating a session that's looking at advances in care and what is the way forward. So, as you would know, thalassemia, there is data that we have close to around 10,000 to 12,000 new children being born with thalassemia major in our country every year. We have a national average of thalassemia carrier state, which is around 3 to 4%. So that brings us to a very big number of thalassemia carriers in the country, and we cannot. And unlike other rare disorders where we are, looking at family and screening families, extended screening is one way of kind of reducing births in the next pregnancy in that family. Thalassemia is not like that. It's a public health issue because you don't need to have a consanguinity to have thalassemia, because the odds of having your spouse being a thalassemia carrier is very, very high. And then again, thalassemia major is supported extremely by the government of India for treatment in terms of from diagnostics to average the regular treatment that a child would require into and taking a child through childhood through into adulthood. But that's probably not enough, and we'll hear from none other than Dr. Prantar today on what is the status, what are the advances, and what all we can do forward. So there are a lot of gaps in our care, and we hope to discuss that in the next 1 hour or so. Over to you, sir, for your discussion.
Thank you, Professor Nita, and it's a pleasure to be here and discussing certain advances, because advances actually mean that they have been there, but whether we can use them, that's a question. So I've kept as a suffix task ahead for India. So I'll just share my screen. And then I'll go. That was the trailer. I think you can see my screen.
Yes, sir.
Yeah. I think Nita's voice is a bit low, so it's difficult to hear due to some reason. Yeah.
I hope it's okay now.
It's better. Yeah.
Okay.
So, hi everyone, and as was discussed, that there have been some innovations, especially in the last 5 years. I'll try to discuss some of them, but then we also need to optimize it for our country. And then I would like to know from you all also how we can do it. So those who are not very much familiar with the patients, I always use this diagram to explain what thalassemia is. And you have to understand that it's an entire spectrum from carriers to so-called intermediate or entities. Here we have them, and then transfusion dependent. So the major bulk of our population, it differs according to the state. Like in West Bengal, 60 to 70% are E-beta thalassemia, whereas in northern and western part, it is more of beta thalassemia. But those who require regular transfusions, they are more visible. Non-transfusion dependent become visible when they present with complications. And what we have to remember is that there is no watertight compartment between this, right? So any patient can migrate from here to here and can come back from here to here. It not only depends on the treating physician, it also depends on how we try to treat the patient. So what are the major challenges in beta thalassemia, be it transfusion dependent or transfusion independent? There's a chronic hemolysis. There is an ineffective erythropoiesis. And because of it, there is iron overload. This leads to multi-organ damage. And all these physical characteristics lead to deterioration of quality of life. So this, in short, is the story of beta thalassemia. We are not taking alpha patients today. So you have to understand that when these cells are maturing and whether there are mutations in the beta thal chromosome 11 or alpha thal 16, ultimately either there is excess alpha chain in beta thal. This leads to inclusion body, and this leads to hemolysis, which is both extramedullary and intramedullary. And in intramedullary, this leads to apoptosis and ineffective erythropoiesis. So there are two arms to this. And why I'm telling you this is because today we are trying to target both these pathways. Another important thing which we sometimes try to overlook or send it below the carpet is the free iron species. We actually look at ferritin, which is the stored iron, but this free iron species lead to a lot of free radicals damage, which cannot be always tackled by antioxidants. So there can be lipid peroxidation, base oxidation, and then oxidation of the proteins, liposomes, endoplasmic reticulum, mitochondrium, and this is where we have to target them. So whatever iron chelations we have discovered, we have still not discovered the ideal iron chelation. Now, if we look at the phenotype of a patient, first let me tackle transfusion-dependent beta thalassemia. The conventional phenotype, as I told you, in our country is either beta thalassemia major or severe hemoglobin E beta thalassemia in the eastern part. How do they usually present? Less than 2 years of age, severe anemia, and they are symptomatic. Now, based on what the infrastructure is available and how we treat them, there are 3 groups of patients. Suboptimally transfused, this was common when I started my career. Then, when we got to transfuse them, we saw that they were inadequately chelated. This happened in Italy about 3 to 4 decades back. Everybody was being transfused, but no one was surviving beyond 30 years of age. And then what we should ideally try to do, optimally transfused, adequately chelated. So the first group who neither receive transfusion nor chelation, what is their problem? Poor growth and development, fatigue, poor performance, skeletal deformities, the typical thalassemic phases, severe osteoporosis, hepatosplenomegaly, extramedullary hematopoiesis, which may lead even to paralysis. Now, if you start transfusing them but not chelating them, what will these patients have? Iron overload related morbidities. What are they? Arrhythmias, heart failure, liver fibrosis, cirrhosis, hepatocellular CA, renal disease, albuminuria, endocrine disease, and if they have to be splenectomized because they were not adequately transfused and not adequately managed, if you have to splenectomize them, then that is an issue. But if you are optimally managing them, then also these complications all do not disappear. So what are the complications? Chelation side effects, ischemic heart disease, because now they will live to an age where, India is the capital of coronary artery disease. They may develop certain malignancies more than others, and quality of life, psychological, social, and economic burden, right? These will be there for all groups. And like government says, we give free blood transfusion. But then also you see most of them are moving about with a huge spleen. That means they are suboptimally transfused or suboptimally transfused and suboptimally chelated. Now let me talk a bit about transfusion dependent and non-transfusion dependent. See, the basic iron overload story is different in them. In transfusion dependent, most of the iron comes from the bag of blood. 200 to 250 milligram of iron per blood packet. So it's a fast rate of iron overload. If you curve it, it goes like this. So even hereditary hematochromatosis, it goes something like this, which was published by Nancy Olivieri and Brittenham long back. And this kind of iron overload, being on where they are being deposited, will lead to pituitary dysfunction, hypothyroidism, hypoparathyroidism, cardiac iron overload, liver iron overload, diabetes, hypogonadism, and bone disease. Now, when I come to NTDT, it is more of ineffective erythropoiesis, and because of the hepcidin paradox, where the body feels that they need to absorb iron, there's increased intestinal absorption of iron. Here, you'll find certain things which were not there, like silent stroke, pulmonary hypertension, proteinuria, glomerular hyperfiltration, venous thrombosis, leg ulcers. Bone disease is present in both. And even if you look at where the iron is deposited in the liver, the cells are different. So, when we talk of dietary restriction, there's no use restricting iron in this group because either way you have to chelate, because one packet will give you 250 milligram, which you can't achieve if you take a even high iron diet for even 3 months. So, how do we try to manage our thalassemics? This is the same all the world over. Blood transfusion, preferably there are certain adjectives before that. What is it? One is leukodepleted, right? One is phenotype matched. One is irradiated. And it should be packed red cells, right? So this is what we should give. And then there are two adjectives. It should be safe, so it does not transmit any infection, and it should be optimum. In transfusion dependent, we say we will try to keep it around 9.5 to 10. In non-transfusion dependent, it is a very tricky situation, and we have not been able to reach a ballpark figure. The jury is still out. The next important thing, as I told you, is iron chelation. Optimal iron chelation. Splenectomy. Ideally, if you manage the patient well, the patient should not receive splenectomy. So at one time in my center, 40% of the patients were splenectomized. Over the years, it has now come down to 8.4%, because that is not a solution. But if there is hypersplenism and you need a lot of transfusion, you might still have to go for it, but it only shows our incapability of managing them well in childhood. Supportive care. We use certain drugs. Hydroxyurea has been there for quite some time, but the good news is now you have hydroxyurea suspension. So it can be titrated according to the body weight of children. Thalidomide we are using, but it is best used in a clinical trial setting so that we can monitor what is happening. Calcium, vitamin D supplementation, folate supplementation, and obviously we cannot afford to forget about routine vaccination. And then cure. So allogenic stem cell transplantation. The best results are when you have a matched sibling donor. Then you can have a matched unrelated donor. And then you can have a haploidentical, which is still not a standard of care, but it is being practiced because of lack of sibling donors. Now, what is new in terms of blood transfusion? So we have come a long way from when it was discovered. What we are trying to do, and it's an automated system, is developing comprehensive patient genotype. So it's not only a complete blood group phenotype, and you do even Kell, Duffy, and others, but it's also about the patient's genotype, and you can do optical reading. You can use a high throughput automatic processing, which takes about 1 hour 40 minutes, and you get a genotype signature of the blood group of the patient. Now, it's very difficult. It is cost intensive, but I think in the long run, we will be able to achieve it. Now, other than genotyping, at least what we can ask for, because we are the consumers, right? We are asking for the blood. We can ask for at least complete blood group phenotype before transfusion starts, right? Because otherwise it becomes a problem. And then in the course, you can ask for screening for autoantibodies and alloantibodies, which are done by most of the blood banks in our country. Have we been able to do something in terms of transfusion-transmitted infections? Now look at this British data. It is old, I agree, but 8 years back, 114 TTI investigations, 110 of them were found not to be TTI, right? So one was probable viral, one was possibly bacterial, and only one confirmed HIV and one confirmed HEV. None with HIV, none with HBV. So you would tell me, why are you showing us UK data? Because in India, we have not even been able to achieve none HIV and none HBV, and some of our children have a lot of viruses. Some even have all three. Now, if you talk of leukodepletion, we always say inline leukodepletion during donation is best. That facility is not available in most of the centers. Bedside leukodepletion filters cannot take care of the cytokines which have already been released. So this is just a schematic diagram showing you how we are automating this entire process, and we are using SAGM instead of ACDA so that we can keep the red cells stored for a longer period. So obviously transfusion services need, but you know, we love when we see such reports. So this was published in February 2025, the long quest for artificial blood in centers in US, UK, even NHS is funding it. Let me tell you, till date, it is not cost effective and it is not very successful in the games of numbers. Yes, we might automate it, we might do newer cell culture methods, but right now we are stuck. Now coming to targeting iron chelators. So deferasirox has been there for more than 15 years. Now we have certain iron chelators SP420. Phase 2 study design was something like this. Phase 3 studies are there. There was another molecule which was called ferritin or deferrithiazine. It caused renal cell carcinoma in mouse model, and so we did not go further. Now, if we are targeting anemia and associated symptoms, we are obviously trying thalidomide in phase 3, phase 4 studies. You also have sirolimus for inducing fetal hemoglobin. Luspatercept is already available in India. Both these trials, Beyond and Believe data is there. Mitapivat and Itapivat trials are starting in India. So, they are pyruvate kinase activators. This, I do not have any data in the public domain of telling you, but you have data from Transcend and Vital report trials, but this molecule is not available. So after targeting iron chelation, you are trying to target ineffective erythropoiesis. What all the molecules have we tried? Erythropoietin, and then 5-azacitidine, decitabine, hydroxyurea, butyrate derivatives, even oral decitabine combined with others, trials are starting. But one which has remained for quite some time is definitely hydroxyurea, and we have learned a lot from our sickle patients. JAK2 inhibitors, or rather JAK inhibitors like ruxolitinib. Activin 2 receptor traps, luspatercept, the first one, and sotatercept. For KID box class O3, I showed you the trials, but we have not got it licensed in India till now. Now, targeting iron dysregulation. So, I was talking of iron chelation. Now we are trying to go beyond it, tackling the free radicals. So, you have hepcidin agonists, increased hepatic synthesis of hepcidin by suppressing the regulator TMPRSS6. Use of exogenous transferrin, which can take care of the free iron, erythroferron inhibition, ERFE. So you have to understand the difference between stress erythropoiesis and ineffective erythropoiesis. Stress erythropoiesis occurs when you're bleeding, right? But that does not lead to iron dysregulation. In ineffective erythropoiesis, you have iron-limited erythropoiesis. They are microcytic. There's hyperactivation of JAK2 kinase, and there is iron overload. So, when we were looking at this, one major discovery was whether these cells can be manipulated using the regulators of RBC production. So, who is the negative regulator in terms of differentiation maturation? TGF-beta superfamily ligands. Now, can we do something here? We tried erythropoietin, it did not work well. So, these are the drugs which are trying. And you even have mTOR inhibitors. You even have our old friend metformin, which actually can do a FOXO3 activation and hemoglobin F induction. This has gone from phase 1 to phase 2. Mini hepcidins, I talked about TMPRSS inhibition, exogenous transferrin, and increase hepcidin expression so that there is less iron overload. So, when I talk of TGF-beta and then whether you can inhibit them, this is how they act, right? So, they act on those TGF-beta, and you can affect the RSMAD851 and then tissue inhibiting factor 1 gamma, GATA, and ultimately you can have effective erythropoiesis. So, it is basically a recombinant fusion protein with modified extracellular domain of ACT-R2B and IgG1 Fc domain. I'll show you how the patient prioritization has been done, and then I'll show you the trial data. So, priority group 1 for this drug is patients who are receiving moderate transfusion, not very high, patients with non-beta 0 genotype, splenectomized patients unable to sustain the transfusion regime because there is shortage of blood, which is a truth in India, and patients with progressive iron overload. Now, these people actually show the best response. If you have a heavy transfusion requirement, your decrease in requirement goes from more than 50 to 33%. So what does it tell you? That it doesn't work well in all groups of patients. So what is the spectrum that we are looking at now? Conventional therapy, which we are following, that is transfusion, iron chelation, supportive therapy. And then you have some pharmaceutical induction of gamma globin like hydroxyurea, 5-eza-decitabine, butyrate, and EPO, right? Add to it your luspatercept and sotatercept. Then you have allogenic transplantation, which has been there. And even in haploidentical, we are using something called PTCY, where the results are better, but they have not been able to match sibling donor transplant in thalassemia patients. And then, obviously, everyone wants to hear about this, so I'll discuss this in detail: gene and cell therapy, nanotherapies in terms of drug delivery. Now, before I go and describe gene therapy for you, let me tell you that in India, we have a lot of problems. But we should realize also that when you have a lot of problems, every problem is an opportunity. And we should take advantage of that. So when a thalassemia patient walks into my clinic at the macro level, my first challenge is, have I made the right diagnosis? The second is, does the patient have resources to treat the disease? Yes, the government is providing funds, but it's not only financial. Are there adequate resources of logistic? Like if the patient comes from 100 kilometers away and then is told the blood bank is dry. Imagine. So it's about infrastructure and it's about skilled human resources. So today we are discussing it because we need more of this, right? And then how do I predict the natural history, especially in E beta? How do I maintain a good quality of life? And here it's not only about the patient, it's also of the family members, the mother who suffers from the conspiracy of silence. They want to hide it because there's so much of social stigma associated with disease. And how do I prevent treatment abandonment? They think, okay, nothing is happening. It's more like a petrol pump. You fill up the petrol and then they go away. There is cure, but it's not available to all. And then how do I prevent complications? How do I prevent death? Now, frankly speaking, let me tell you that all of this are challenges at my level, but they are also opportunities. You may ask me why. Let me tell you how. First is every medical student, paramedical student, even village health workers should understand that early diagnosis is essential before a blind blood transfusion. Once you transfuse, hemoglobin F may be suppressed lifelong. And then resources. Provide info where the resources can come from. You have Shastha Shati in our state, and you have Arogya Mission and Prime Minister's Shastha Yojana. You have a lot of insurance. Networking. Some may have red cell units like cancer centers. They need more platelets. Why can't we utilize them? And most important is you have to convince the policymakers. Train. Predicting the natural history, I'll talk of looking at the data through registries. How do I maintain a good quality of life? Educate the family, educate the society, and provide comprehensive care by a team. like Dr. Nita has developed. Single window under a single roof. And how do I prevent treatment abandonment? Frequent monitoring, if necessary, through telemedicine and digital methods. Individualizing the treatment, and remember, never give up. Heavy iron overload, I have used IV infusion of Desferal for days. So the message is we can always try. At the national level, obviously, awareness, comprehensive care, financial handholding, transfusion support. So, transfusion services have to improve, but that will not only benefit the thalassemia patients, they will benefit other patients also. Mental and social health has to be taken care, and we have to know what works and what doesn't. But if you ask me what is the greatest challenge at the national level, I have not talked of any technology for that, and that is prevention. Why are we not preventing this genetic disease, right? So now I think most people, they tell me, okay, what about gene therapy? Recently, I got a child. I shouldn't call him a child. He's an adolescent now. He's 16 years old. The mother said, I've heard that at 2.5 crores, I can get gene therapy for him. You please recommend it. I said, yes, I can recommend it. But have you seen his ferritin level? His ferritin level is 10,822. Do you think that gene therapy will work when this iron overload is damaging the organs? So there are different ways of gene therapy. Betipiglogene autotemcel, tongue twisters, Zinteglo, it offers transfusion independence in beta thalassemia major. And then hexagamglogene autotemcel, I call it Hexacel. It's CRISPR gene editing. The major studies have been engaged and climbed, and they have been approved. But how do I integrate it? Not only it's about insurance coverage or compassionate access. You develop your own technology. Atmanirbhar Bharat, right? And for that, you get all the basic science institutes together. Improved formulations, just not FCT or something. Try how to best utilize combination therapy. If necessary, you can promote combinations, but train practitioners so they use the adequate dose. Sometimes they give it not every day, and the effective dose comes to 20 milligram per kg per day of deferasirox, which is grossly inadequate. And can we implement T2 star MRI, which actually helps more in patients who have a normal ferritin? We have so many MRI machines. We have even 3 Tesla machines. And then luspatercept, first-in-class drug. It has been DCGI approved. This was the data when it was first used, but I have already showed that it can be used only in certain groups of patients. So if you use it, more than 33% reduction in transfusion burden. But let me tell you something very frankly. If I had to come and take 2 units of transfusion every time, and now I take 1 unit, but still I have to come 12 times in a year, does that mean reduction? But that is how the trial was designed. So there has been the Italian guidelines which have been published in 23, and they say a patient-tailored approach is essential. Further studies are needed to optimize patient selection and management. So for beta thalassemia, ineffective erythropoiesis, you can use it even in regular transfusion because it has some degree of iron removal effect. But remember, in NTDT, it can increase the hemoglobin level by more than 1 gram with hemoglobin less than 10. That has been shown in the Beyond trial. It can reduce transfusion burden in the Believe trial. But who will believe that the load of financial toxicity will be reduced? Maybe 1 minute on oral pyruvate kinase activator. So they can decrease the 2,3-TPG. So it works both in sickle and in thalassemia. And trials are starting where hemoglobin increases oxygen delivery improves. The hero, gene therapy and gene editing. So, first of all, let us understand from fetal to adult, there are some switching mechanisms, and there are certain pathways like the BCL11A, SOC6, which actually lead to an efficient switching. You have about 250 point mutations. They all downregulate the beta globin gene. So there are transacting mutations in GATA1, TFIIH, KLF1, and then we have 619 BP deletion, IVS 1511, and all those things. So, what is the difference between gene therapy and gene editing? Gene therapy addresses whole gene or multi-gene disorders. Gene editing targets specific genes or even single base pairs. So thalassemia is a good target. Here, it involves introducing functional genes. Here you can use CRISPR-Cas9, which acts as scissors. Longevity of effects. Gene therapy may require ongoing treatments as the introduced genes may not integrate permanently. This gene editing actually can have long-term effects. So what has been done till now? I talked of betibeglogin, that is Beticel, transfusion independence in 20 out of 22 patients. They started with 23 patients. After myeloablation with busulfan, they used it. Average hemoglobin level 11.7. At 12 months, it went down, but it was still 8.7. So this was published 3 years back, and it has been licensed. But what do you see? Every patient is different, and these are the dots everywhere. So some may not reach that. Transfusion requirement after Beticel, just to show you that only a few have received packed cell transfusion. Most of this dark blue have not received. So this patient and this patient continued to receive packed cell transfusion. So what did they conclude? Sustained a mutated hemoglobin A, T87Q level, and the total hemoglobin level was high enough to enable transfusion independence with a non-beta 0 genotype, including those younger than 12 years of age. Now, let me explain to you what gene editing is. So you're editing, right? You can manipulate RNA by using either ASOs, which can be AMOs or SSOs. So I'm not going into all those terminologies like single strand and what you do, but you can also manipulate the small nuclear RNAs, U7. And other than RNA manipulation, you can do genomic manipulation using nucleases, which are zinc fingers or talons, CRISPR-Cas9. These experiments are being carried on in India, and there are certain nucleus-free strategies also, right? So this is what gene editing is. You can use Bs and Ps, but they have not come into clinical trials, and you can use nucleotide adducts for doing it. So what do we basically do? We take the normal in RNA and then we splice it and then we repair it, right? And I talked about ASOs. When you correctly splice it, and then you see that you can produce beta globin. So it's just like how we repair potholes. Previously, the pothole was there. You just take that out and you use your CRISPR-Cas9 to remove it and techniques, and lo and behold, the road is ready. U7 small nuclear RNP, zinc finger, talon. I'll not waste my time on this, but we are not only trying to correct the gene defects, we are targeting the HbF repressor, which is TAL1 and GATA1, so that we can get more of fetal hemoglobin. We are trying to reproduce HbFH mutation other than trying to do gene repair. So be it zinc finger or talons, ultimately we are correcting the genes, right? This is a beautiful review article. If someone wants to read about it, how we are trying to do gamma globin reactivation or beta globin gene repair, you can go and have a look there. Now we are trying to be more smart. We are using lipid nanoparticles with plasmid nucleic acid, single strand, get incorporated and repair it. So I talked about nano and I just give you an answer. So where are we today? We can use stem cell transplant to cure it. We can use hydroxyurea to alleviate the ineffective erythropoiesis. We can use gene therapy and gene editing. But what do we do about reactive oxygen species regeneration? We need better chelators. This is still an unmet need. And for inactive erythropoiesis, we are trying to use ruxolitinib, which will go out of patent in another 2 years. We are using luspatercept, expensive, sotatercept, not available, ferripotin inhibitors, trials going on. And with iron chelation, we are trying mini hepcidins and TMPRSS6 inhibitors. So I told you about my challenges and opportunities. Now, if you ask me, what is the task ahead for India? It is 1, prevention, 2, prevention, 3, prevention, 4, prevention, 5, prevention. Let us not forget it. I have shown you all the gene repair techniques, but the simple technique of prevention has to be done. Registry mapping, micro mapping, education, political will has to be there. We are talking of sickle cell eradication. Why can't we talk of eradicating thalassemia? Point of care screening. We do not have good references till now. We have certain devices. And we have to be better managers in terms of implementation management. As far as prenatal diagnosis is concerned, I'll talk about pre-implantation genetic diagnosis in one slide. But remember, we actually need it to make it non-invasive so that you look at the circulating fetal cells in maternal circulation. That makes it easy for the mother, right? There is still a 1% chance of adversity if you do chorionic villus sampling. Pre-implantation genetic diagnosis has its own problems, but it is being practiced in certain centers in India. And then what happens to the affected individuals? We have talked of prevention. Take good care in terms of comprehensive care, transfusion services, more clinical trials. And, this is not available in the market. Empathy, right? So, research and innovation. We say we know a lot about thalassemia. Do we actually know how we can make our patients better? There has to be academia-industry partnership, basic science collaboration, especially in terms of gene therapy, gene repair, and out-of-the-box thinking. This is essential for India. So improved transfusion protocols, we should at least have phenotype-matched, leukoreduced, irradiated, NAT-tested, or any molecular tested blood. Component separation, cardiac and liver T2 MRI, precision-guided chelation. This is also being tried. How do you implement MRI monitoring in India? Radiology partnerships. When I got the technology, none of my radiology colleagues or technicians were willing to take the training. So please, radiologists need to come on board. Develop a protocol. It can be open source. It need not be FERI-SCAN. And there are other protocols. The physician should be trained to interpret. Now, pre-implantation genetic diagnosis is when you have the small, 4 to 6 cell and you select it, do NGS best, see which is, but don't try to also do HLA matching and produce designer beans. So how do you expand genetic services in India? Carrier screening, premarital counseling, expand PGD through ICMR accredited labs, and financial assistance for carrier couples who do not have the facility near to their homes. Bone marrow transplant innovations, 70% cure rates, going up to 80, but most of them, they do not have donors. We are trying to reduce the toxicity with thiosulfan-based conditioning, and we are trying to get a better at haploidentical transplant. Strengthening, you have to have a national donor registry, donor partnerships, and accredited centers. The data should be transparent. It should not be on the street hoardings, right? That we do all this. So, ICMR, state programs, medical councils, it cannot happen in isolation. We have to integrate it. I think if you tell me what is important, chelation, combination, and then BMT, genetic counseling should come here. Here is a huge gap. And then gene therapy readiness when we develop it. So National Health Mission, Ayushman Bharat, state rare disease programs, and I think ORDI should play a major role here. We all are patient advocates and we have to do it. But if we want to know what works and what doesn't work, we have to have registries to understand treatment outcomes, therapy utilization, and research collaboration. Patient education. This is so important. Patients run after certain things thinking this will cure my child of thalassemia. Tell them the truth. Yes, there are only some few chances of cure, but we can give you a normal life if we listen to us. Let us have multilingual apps for physicians who want to know what is happening in 2025. You have lentiviral gene addition, Beticel, gene editing targeting BCL11A, apotransferrin, luspatercept, mitapivat, and other OX3, and benserazide, sirolimus, and IMR 687. These will keep on coming, but you have to prevent it. And innovation in thalassemia is like Wi-Fi in rural India. Slow to reach, but life-changing once it does. When the patient, the family, the society is empowered. Medicine is a social science. Think of the bigger picture. Thank you for your patient hearing. I'll stop sharing.
Thank you, sir. Is my audio better now?
A bit
You
better,
able to
but
hear?
if it's louder, it could be far better.
Okay. Thank you, sir. Thank you for your detailed discussion on the pathophysiology first, followed by what is standard of care and what are the newer advances. And thank you for also highlighting that each problem is an opportunity for us. And like in a country like ours, where we have a huge volume of patients, and that should make us, we should consider this as an opportunity, do work on it, and make us global leaders in that problem. So I have three questions for you, sir. The first question is, now we have a lot of access for high-end treatment like bone marrow transplantation. But like you said, the basic treatment, like that ferritin, that lady whose son had ferritin of 10,000, basic treatment is still suffering. So for a transplant outcome also, that good treatment, the basic standard of care is extremely important to have a very good outcome for either transplant or if suppose somebody is going for gene therapy as well. So what according to you would be something that helps us establish a uniform standard of care for thalassemia in the country? Like
Yeah,
tuberculosis has a uniform treatment across the country, wherever you are, whichever district, your tuberculosis treatment is standard. But that is not yet for thalassemia. So how can we do that?
yeah. So, uh, on World Thalassemia Day, we were discussing it in the ministry's corridors also in the state of West Bengal. The most important thing is, first of all, you should not restrict care of thalassemia to so-called thalassemiologists. I think this is very important. It should be integrated into care where pediatricians, physicians all treat them. This, and then they can have a bit, just a simple checklist, a workbook, right? So I see this is the spleen size. If the spleen size is increasing, maybe the transfusion is not adequate. If the transfusion requirement is more, contact the transfusion medicine department, let them look for antibodies. If the spleen size is increasing, can we give them some so-called additive transfusion? See, can we use hydroxyurea? If we use, do we use the correct dose? How long should we wait? And also, the most important thing is that do not tell the patients that, you come for transfusion, then you come to my OP clinic once again where I'll examine you. This patient is with us for so many hours. Why waste their time? Why waste their school days? So I always say comprehensive care means that if you have a hematologist, it's fine. If you don't have one, monitoring can be done by any nurse or any paramedical person, even a counselor. The checklist should be there. Unless the checklist is filled, they should not even come to the next level. Because you do not do the basic things correctly, and then you think, okay, now let me do a transplant. That doesn't work, right? You have seen it, I have seen it. So to make it uniform, I do not know. When I talk to National Health Mission, there are these guidelines from NHM also, right? But then they say health is a state subject. I thought it's a concurrent subject or a state subject, whatever, but it should not remain on pen and paper. I would want a workbook which is there on the wall. Most of the patients in my district thalassemia units, because I'm out of the system now, so they tell me, sir, no one examines us. See, it's not about just writing transfusion and putting in that blood. A patient told me, I feel like a car going to a gas station, getting gas filled and going away. Thalassemia care is not that. So I think that because now you are also an accredited center, but guidelines should be made for India and the basic minimum, right? Because I have so many patients coming and telling me, why is luspatercept not free? Right? So I say, yes, great. Nothing is free. If it is free, it will be taken from your taxes. So are you willing to pay more tax? And then it will work only in a subset of patients. Why don't we actually give optimum transfusion and at least chelate? So anyway, I might sound a bit pessimistic, but I'm always optimistic. And the most important thing here for policymakers is we show them the outcomes. Because country is run by economists, right? So I always tell, visualize the data and put it to the policymakers.
Yeah. So the takeaways from your answer are like that we should be developing a point of care checklist at least for every nurse or every physician who is seeing a thalassemia patient. It can be a physical one, it can be even an app-based one, and there should be an easy algorithm as to what to do if there is a problem. Thank you, sir. So next question is regarding, you mentioned regarding data in thalassemia. So in Western centers that are managing thalassemia, they have longitudinal data of growth, ferritin, transfusions, etc. How can this be integrated? In India, already we know that there are many registries. You'd mentioned already developing a registry as well. So there are already, there is a sickle cell portal that is taking data of thalassemia patients. There is an ICMR registry. What is your suggestion for integrating all this longitudinally so that we know how patients do?
Yeah. So when we talk of Arogya Bharat Digital Health Mission, right? Interoperability. So why can't this data be put in somewhere? The biggest question I have faced is who puts in the data. And I feel the person who suffers most can put in the data, right? If you give a user-friendly app to the patient, they will at least put in their hemoglobin level, ferritin level, height, weight. And if it is better if the healthcare provider puts it, but if you do not do it, at least something is better than nothing. And if you ask me, I am on a mission to develop an app which would be very easy to use, where they can just upload their reports. There are certain apps, but those are developed by US and others, so they have their own problems. In India, so that the patient actually has something with him or her. And then, once the data is there, from the technology point of view, making the technology of one state's registry talk to another, go somewhere else, is not difficult. When a NGO like Hemophilia Federation could develop a registry, and that data still goes to WFH, right? So why can't we do it for thalassemia? I do not know why it can't be done.
Yeah, very true. I think it's just a matter of somebody taking initiative and doing it. And
Yes,
we look
yes. That
forward to your
leadership and,
practice and
the will, and I can tell you the patients will partner us. There's no doubt
Yes, sir.
about it. And they
Very
know
true.
more about themselves than us because they're living
Correct.
with that disease.
So the patient interface is very important. And
Hmm.
as the patient grows, the responsibility of the patient towards his or her own health also increases. So that will improve compliance as well.
Yeah.
And one final question, sir. You mentioned regarding screening and that the only way forward is prevention. So we have so many avenues for prevention, as in we could have so many avenues for prevention. We could do prevention of lay public, like in sickle cell mission, I think in high risk areas, lay public are being screened. We could screen schools, colleges. So a lot of NGOs do school, college screening, blood donor camp screenings for thalassemia carrier state. And we can also do just a residential area targeted screening, etc., which are being done by in a small scale by many NGOs. And we could also target antenatal screening, as in the first trimester when they come in. So probably that's the absolute last time when we can do it. So what, according to you, is the best or a cost-effective screening technique? The screening, whom should we screen? Who's the target to be screened? One. And in this era of AI, can AI help us in improving the mapping of thalassemia for the country?
Yeah. So I'll take the earlier question first. I will not answer this as a hematologist because as a hematologist, I could be passionate that yes, let us screen even college going children, school going children. It has been proved by Roshan Kola and others that it is of no use. It has been published. They never remember, right? If you ask me as a public health crusader or a policymaker, the most effective is antenatal because you can get the result immediately. Now I understand that the ASHAs are being incentivized so that they are registered during the first trimester. But I also came to know that in my state, at least like my previous state, West Bengal, in the mother and child card, there is no place to even record the HPLC data. Now, how can this be done? If I think this is effective, we have to integrate it in antenatal screening. Now, let me talk of our experience in antenatal screening. 50% of the time when we got the mother as a carrier, the husband refused to come for screening. But what we did was we contacted the local police station. Okay. Now people might criticize me for that, but we did it. And then 50% of them came. Then when they were screened and they were found to be carriers, some of the people were not interested also in getting the report, right? Then how do you do a post-test counseling? So it is very important that we integrate it into the pregnant mothers monitoring. You have a prime minister's Yojana where every month they come together. Can't someone see whether that lady has been screened or not? And then whether the husband has been done or not? I think the major obstacle now is if both, then do you have a facility for prenatal diagnosis? Now you are developing, planning to send person to moon, to Mars. You are sending precision missiles and you can't develop this. This is just because we are not looking at it as a problem. If Rafale jets can solve our problem, prenatal diagnostic methods can also solve our problem. Because if we can prevent the birth of one thalassemic, we are saving at least 50 to 75 lakh rupees. So as I told you, visualize the data, try to prioritize the antenatal screening. It's more of a managerial issue rather than, as you said, obviously we have to have better point of care. We would need even, mother's blood, fetal cells, not invasive. Maybe, yes, sometimes if there are multiple issues coming with thalassemia, you go in for pre-implantation genetic diagnosis, but at least we should try to do and screen both in the first trimester in terms of antenatal screening.
Regarding
And
AI.
your AI question, yeah. So from BC, that is before ChatGPT, we are now into AD, right? I always say after DeepSeek. Using AI and machine learning to look at the indices. And that is where integration of data is important. Every state is doing a CBC. Look at that data, look at the perspective. We know that hemoglobin E carriers do not have microcytosis hypochromia, but there can be something which the machine can look at it. And if you use it, and then registry data, I can tell you, if you give the longitudinal data of at least, say, 500 patients, our models can predict whether an E-beta thalassemia will become a transfusion dependent or a non-transfusion dependent. We have to do it. But let me caution you, we in technology say garbage in, garbage out, gold in, gold out. The data should be of good quality, and then only AI will be able to do its job.
Thank you, sir. And I think, like you mentioned, some labs are actually giving us, when you have a CBC, it will give you whether this could be a thal trait. But then a pathologist is actually looking at it and doing it. But that, with help of AI, it has to be integrated to every single CBC of every district, every primary health center report. Then that will really help us, because there are like millions of CBC reports that are going to come out every day. So that will really help us help in this journey of identifying carriers. And thank you very much for that discussion, enlightening discussion. And I thank the Organization of Rare Diseases India for this, for taking up this topic, and especially the part on the task ahead, which I think has helped us discuss more. And usually we discuss what is the theory and what's our experience and leave it at that. And this part of what we can do actually has sir has raked his brains and brought out so many ideas, and I think we have a long way to go in implementing many of that. Thank you.
I think there was one question. Yeah,
okay,
Dr. Devabroto Sarkar. Okay, it's a comment that registry is the most important step in it. I think we should make it mandatory to register, make it a notifiable disease. So, you know, any lab which does an HPLC. And then what about having a national helpline number for Indian thalassemia patients? Absolutely. You know, and you can have a person manning it, and then you can have AI chatbots manning it. So that kind of helpline is very essential. When we do programs for Doordarshan, you can't believe people from remote areas. There are some people, there was an elderly lady who called up and said, you know, I have done a thalassemia test for my daughter, but no one is being able to tell me that what should I do. See, if they are aware, they are doing it, it is our responsibility to take the next logical step. So I entirely agree that we need a helpline. We had such even during polio eradication, even during HIV, you know, we had Buladi and all in our state. We need it. And I need people from outside our arena, you know. We need people from IT, we need people from advertising, we need people who brand things. All should come together because it's a social movement. That was the only question I had in this chat box.
Yes, sir.
Yeah. I have answered it live.
I think we can close the
Yeah.
session since there are
So,
no many
Dipanjana,
more.
are you